I have a problem. She's my boss. So I can't contradict her too much.
Boss is always right.
Boss is always right. Anyway, I'll try and do my part of the argument. And these are my financial disclosures. Again, none relevant to this. So what I'll try and show you is, I'll talk about the challenges that we have regarding ophthalmic generics. I'll talk to you about composition. I'll talk to you about efficacy. And I'll talk to you about patient preference. So one of the biggest challenges that ophthalmology has when it comes to generics is that it's very difficult to measure bioequivalence, because we cannot be taking aqueous tabs to measure equivalence. It's not like for systemic medication where you look at blood levels and say that it's equivalent or not. And so that is one of the reasons why we still have concerns about a lot of generic medications in ophthalmology. In terms of composition, you look at this paper, which was published in the Canadian Journal in 2012, where they found that generic timolol maleate, two different forms, in Canada, had 60% of the daily therapeutic dosage when compared to the branded product in the US, and 2/3 of the therapeutic dosage in Canada. So definitely, composition was not as was expected. Again, coming to composition, you look at this study, which looked at the active ingredients and preservatives between brand name and generic topical glaucoma medications using LCMC. And these are some of the particulate matters that they found that were greater than 1 micron in size. As you can see, one is almost 100 microns, and these unidentified floating objects, God only knows what they do in the eye. And when they looked at the number of these objects, what you find is, you find it both with the branded and the generic, and this is the baseline concentration, and this is the concentration when it has been stored at 25 degrees for 30 days. And you can see an 8% increase in these floating bodies in the branded product, and look what happens in the generics. You go from 100,000 such particles in every ml to 156,000 such particles in every ml. So it's not just about composition, it's about how the product is made, and that is definitely appears to be an issue. You again look at this study, the same study, which looked at the concentration, the baseline concentration of the drug, and you can see that the baseline concentration actually went from 105% to 115%. 105% is within, all are just within the accepted range of concentrations for the drug. See what happens at 35 days, 95%. And in the other two, concentrations drop to under 80%, which is actually not acceptable. It should be more than a 90% concentration at all times, and you look at the estimated time to a 90% concentration if the drug continued to degrade at this rate. For the branded product, 50 days. For the other two, 12.5 days and 12 days. And this is when it was stored at 25 degrees Celsius. In our country, especially Coimbatore, the last few days, the temperatures appear to be closer to 50 degrees than 25 degrees. And see what happens at that concentration. Even at 30 days, you are down to close to 2/3 of the concentration. And look at this, at 50 degrees, the branded product still seems to hold on to 90% concentration, while the other two don't even last 10 days. What about this product with this study which has come from All India Institute, which looks at the stability of latanoprost using controlled degradation and patient usage simulation studies. So what they did is they had somebody come and take a drop out of the bottle every day, and then they measured what happens. So this is the baseline concentration, and look here. So this is what the concentration of latanoprost is supposed to be. And this is the concentration of the branded product. Everything else is either up there or slightly lower. So these are probably not a big issue, but these are definitely a concern, because in the original studies for latanoprost, it was shown that when your concentration goes up, your efficacy actually comes down a little bit, as well as an issue with side effects. So what happens after 30 days of simulated use? Out of the 6 generics that they looked at, you have 3 which are fairly reasonable concentration, 90% and above. The other 3 are actually 70% and less. And this was in not patient usage, this was being done at the hospital by somebody taking 1 drop out of the bottle every day. Dr. Shanta has already referred to this study, and the study was a pilot study, so it wasn't actually powered to pick up a difference. But I'll just show you this. We had group A and group B, and group A was in general a better responder. So what happens with group A when we started them on Xalatan? You got a 40% drop, group B about 25%. When you switch them, group B actually, goes up a little bit, and group A gets a further drop. So in both situations, the branded product actually did better than the generic. And if you look at the proportion of patients who were reaching an intraocular pressure of, let's say, less than 16 millimeters of mercury, that was fairly significantly different. And this was a crossover study, so the same patients had both things. So when you come to the patient experience of the transition from Xalatan to generic latanoprost, patients found Xalatan, this is all statistically significant, easier to instill, more comfortable, and easier to bottle, easier to open, sorry. And generic bottles failed to last a month for about 20% of patients in this study, and 75% of patients preferred Xalatan to the generic, and 22% wished to recommence Xalatan. So this is what was found, this is what patients preferred. So I have showed you that composition, efficacy, and patient preference all matter, and all are in favor of Xalatan. I would like to ask you this question before we finish. Would you like to have your next Big Mac here or here?